Thank you. Thank you for joining us at Medical Grand Rounds today. We have a speaker coming from the Division of Nephrology. And before we introduce the speaker, just a quick reminder, if I can ask you to please enter your questions in the chat at the end of the presentation. And also please let us know that you were present at today's rounds by answering a brief survey that will be sent to you right after Medical Grand Rounds. You should have received a letter confirming your attendance at Medical Grand Rounds by Grace Katouf. You may have received the first one, which had not quite the right number of rounds attended, and you would have received a second one during the weekend. So please look for that in your inbox. It comes from Grace Katouf, and it will confirm how many Medical Grand Rounds you have attended. If you have any problems with those numbers, please let us know. So I'd like to thank Rita Suri for being here and for inviting our special guest speaker today. Rita, I will give you the floor.
Great, thank you. It's my very great pleasure to introduce Dr. Ron Wald as our visiting professor for Grand Rounds today. I've known Ron for many years, and he's a dear friend, supportive mentor, and admirable colleague, but he's also a world-renowned trialist in nephrology. He's currently a professor of medicine and health policy and management and evaluation at the University of Toronto, and he originally grew up in Montreal, completing his medical school at McGill. He went on to University of Toronto to do internal medicine and then completed a Master's of Public Health at Harvard and a research fellowship at Tufts University. Since then, he's really built a career in trials in nephrology and has more than 200 publications, including in prestigious journals such as the New England Journal of Medicine and JAMA. And so it gives me great pleasure to introduce him today to present AKI an update. Of note, he is currently doing a sabbatical as a visiting researcher in Israel. So it's late for him, but we do appreciate him joining us today. Turn it over to you, Ron.
Thank you. Thank you so much, Rita, and I'm very grateful. It's really a privilege and a pleasure to be speaking at Medical Grand Rounds today. Thank you for the warm introduction, Dr. Giannetti and Rita. Thank you for being a great role model and collaborator, and for everything you do in leading the Canadian nephrology community. It's especially meaningful for me to be giving rounds at McGill, which is my alma mater, an institution that really fundamentally shaped me as a physician. Montreal, as Rita said, is also my hometown and a place forever close to my heart, even though I left Montreal for residency in Toronto over 20 years ago. The two most impactful people in my upbringing, though, in Montreal were my parents, my late parents, Hadassah and Ted Wald. They would have been especially happy to attend these rounds since McGill and its affiliate hospitals, where they had so many beloved and caring doctors, was the only academic institution that counted in their eyes. Some of you might know that I was initially supposed to give these rounds in early March of last year, but in the weeks leading up to that talk, I was quite excited about it, and I secretly hoped that my dad would be able to attend. He never heard me give rounds, and though he knew a lot about my job, he was worried that I worked too hard and really didn't understand why I spent so much time doing research. Tragically, a few weeks before those scheduled rounds, my parents both contracted COVID and passed away, first my mom and then my father about a week later. My brother, who lives in Montreal, then became critically ill with COVID. During that very difficult month, my family was the beneficiary, though, of the incredible skill and dedication and compassion of so many physicians, both attending and residents, nurses, allied health staff, and many others at the Jewish General Hospital. I was personally overwhelmed by the outpouring of support that I got from my friends and colleagues at McGill. I felt like I was really back at home. And so for those of you who cared for my family during that time, who might be on this, at this meeting, attending this call today, this Zoom meeting, thank you from the bottom of my heart. And of course, I wish everyone health and safety as you battle this wave of the pandemic. Moving on to acute kidney injury. My objectives for today are to review the current diagnostic criteria for acute kidney injury, as well as their limitations, discuss the recent evidence that we have on the initiation of renal replacement therapy for AKI in the ICU, and learn about the health risks faced by AKI survivors. So what is acute kidney injury and why does it matter? until recently, AKI, or the field that we now call AKI, was a field plagued by multiple definitions. The most common definition was a 25% rise in creatinine. Some people used, a more modest rise in creatinine or a larger rise, and there was really inconsistent terminology. We tend to call it acute renal failure, acute renal insufficiency. And there was a feeling in the critical care nephrology community that we had to unify things a little bit. And the first effort towards this was by the Acute Dialysis Quality Initiative. They developed what's called the Reifel criteria. I bet you not many people other than nephrologists and intensivists will remember this in 2004, and then went on to the Acute Kidney Injury Network criteria in 2008. In 2012, the Kidney Disease Improving Global Outcomes, that's the group that oversees and develops clinical practice guidelines for nephrology, developed their criteria for acute kidney injury. And you can see that there are really two parallel sets of criteria, one based on increments in serum creatinine, and another on the right side based on the severity and duration of oliguria. Very briefly, to qualify for a diagnosis of acute kidney injury, you have to have a minimum 50% rise in your creatinine or a rise of 27 micromoles per liter from your baseline. And as the severity of the creatinine increase goes up, similarly, you get classified into higher stages of acute kidney injury, noting that if the patient requires renal replacement therapy for their acute kidney injury, they're automatically classified as stage 3. By the same token, if there is oliguria, at least defined as a minimum or a urine output that's less than 0.5 mils per kilo per hour for a duration of 6 hours, that also qualifies you for stage 1 AKI, and so forth as the duration and severity of the oliguria worsens. So how were these definitions derived? Was it merely a matter of academic nephrologists and intensivists sitting around at a conference and kind of coming up with these cutoffs? A really fundamental paper that helped shape how these definitions were derived comes from Glenn Chertow and colleagues, published almost 20 years ago now. And what they did was look at over 9,000 patients admitted to the Brigham and Women's Hospital in Boston. And without prejudice, they looked at a variety of increases in serum creatinine and looked at which increases were associated with higher mortality and other things like length of stay and costs of care, all very meaningful, important things. So it's not surprising that patients who had a doubling of their creatinine from baseline had over a 6-fold rise in the risk of death in hospital. An 88 micromole per liter rise was associated with a 10-fold increase. 176 micromole per liter rise, this was really 2 milligrams per deciliter in the US units, was associated with a 16-fold rise in mortality. So these are big rises in creatinine. None of us are surprised to see these associations. But what was really interesting was that even relatively modest rises in creatinine, like a 50% rise from baseline, a 27 micromole per liter rise from baseline, these were both associated after full adjustment for demographic and clinical criteria, independently with a 4-fold or more rise in the risk of death. So it made us realize that even modest increases in serum creatinine are associated with mortality. And this is indeed what informed, to some extent, the classification scheme for AKI that I showed you earlier. What about in the ICU? This was an international study that I think encompassed 5 continents, almost 100 intensive care units around the world, 1,800 patients. Each unit contributed anywhere from 10 to 65 consecutive patients admitted to their ICU. And remarkably, these investigators showed that 57% of patients admitted to the ICU experienced an episode of AKI, the most common of which was stage 3 AKI. And again, perhaps not surprisingly, in a graded fashion, the odds ratio for death as the AKI becomes more severe goes up as well. But to remind you that even stage 1 AKI in the ICU was associated with over 2-fold risk of death. So in a nutshell, these studies showed us that acute kidney injury has, and its classification scheme really has a prognostic basis. That's really how the classification scheme was derived. And acute kidney injury is unquestionably associated with adverse outcomes, even mild acute kidney injury. But we have to ask ourselves, does acute kidney injury actually mediate adverse outcomes? In nephrology, we ask ourselves, do people die of AKI or are they dying with AKI? And should the prevention of acute kidney injury therefore be the focus of clinical intervention? After all, is acute kidney just a surrogate marker for bad things that are going on with the patient, or should it in and itself be a target for therapy? And to be a bit more provocative, I'm going to ask you, is acute kidney injury always bad for patients? So I want to perhaps use a scenario from an ambulatory care to illustrate one of these dilemmas. This is a 65-year-old man with established coronary artery disease, hypertension, and hypercholesterolemia. His serum creatinine at baseline is 150 micromoles per liter with an eGFR of 49. He has negligible albuminuria. His blood pressure repeatedly, both at home and on ambulatory, 24-hour ambulatory monitoring, is in the range of 140 over 95, and he's on therapy only with amlodipine 10 milligrams per day. The clinician adds chlorthalidone 25 milligrams daily and telmisartan 80 milligrams daily to this regimen sequentially. And now that you're seeing him, his blood pressure has come down to 115 over 75. His creatinine has maybe gone up a little bit to 160. And so what inspired this escalation in blood pressure control therapy? Of course, we're all familiar with the SPRINT trial, which showed us that in patients who have a high risk of cardiovascular disease, including those with chronic kidney disease, just like our patient, targeting a blood pressure lower than 120 systolic led to better outcomes as compared to a target of less than 140. And specifically, intensive blood pressure control conferred a reduction in major cardiovascular events, a reduction in the risk of incident heart failure, and a reduction in all-cause mortality. So coming back to our patient now, he develops COVID-19 pneumonia. He's admitted to a medical ward. He's febrile. For the preceding days prior to coming to the emergency room, he had decreased oral intake, but he was taking his medication religiously. He also had some diarrhea as well as part of his COVID. He's admitted to hospital for oxygen and dexamethasone. His blood pressure is a little lower than his baseline, perhaps 105 over 60, but his creatinine has risen dramatically from about 160 prior to the hospitalization, now to 350. And so we have to ask ourselves, why did this happen? Okay, why would it be that a patient who is on 3 medications for blood pressure, why would he be at higher risk of AKIs compared to someone perhaps who is on a less intensive regimen for their blood pressure control? So I want to come back to the concept of renal autoregulation and speak about how our kidneys regulate or how they maintain GFR in the presence of hemodynamic insults. So in this particular hypothetical case, we have a decrease in the ECF volume related to the patient's diarrhea, leading to a decrease in renal perfusion. This is probably also exacerbated, I might add, by inflammation related to their COVID infection, but I don't want to complicate things. And in response to this hemodynamic insult, our kidneys maintain GFR by vasodilating the afferent arterioles of our glomeruli, and this is mediated through vasodilatory prostaglandin. And at the other end, there's vasoconstriction of the efferent arteriole, and this is mediated primarily by angiotensin II. But this particular patient, for example, who's on a diuretic, on chlorthalidone, this could certainly perpetuate its ECF volume contraction and make the hemodynamic insult worse. But importantly, by being on the angiotensin receptor blocker, the telmisartan, this might prevent maximal efferent arterial constriction and thereby impairing his ability to properly autoregulate and maintain his GFR, thus making him more likely to develop severe acute kidney injury in the face of what seems like a relatively modest insult. Of course, the patient has other risk factors for AKI, including his underlying CKD, perhaps atherosclerotic involvement of his renal vasculature, his hypertension, as well as, of course, the severe COVID infection. So when the investigators from SPRINT went back and looked at the patients in the trial, they actually found that there were about 300 patients out of over 9,000 who had an episode of AKI. They were hospitalized with AKI. And surprisingly, patients in the intensive arm, those who seemingly had a better cardiovascular outcome, they were more likely to have an episode of AKI, about a 60% higher risk of acute kidney injury over the course of the trial follow-up. But what was also really, really interesting and perhaps reassuring to us is that even though there was a high risk of AKI in the intensive arm, most cases were mild and reversible. Scenario 2, this is for the cardiologist in the room. You have a 57-year-old woman with idiopathic dilated cardiomyopathy who presents to hospital with 3 days of progressive dyspnea and lower extremity swelling. She's on multiple important medications at home, Entresto, empagliflozin, spironolactone, bisoprolol, and a baseline furosemide dose of 40 milligrams BID. At baseline, her creatinine is 110. She presents to the ER with dyspnea. Her blood pressure is 150/90. She's tachycardic, statting 87% on room air. Her JVP is elevated, crackles on pulmonary auscultation. She has ascites and lower extremity pitting. Her chest X-ray and BNP are both compatible with heart failure. Her creatinine has risen modestly to 150. She's admitted to the ward, started on intravenous furosemide, and 3 days following admission, she's starting to feel better. Her dyspnea is better subjectively. She's lost about 4 kilograms from admission. Her blood pressure is a bit better. She's still requiring oxygen, though. And she has, on exam, persistent clinical evidence of heart failure. But her creatinine has risen now to 250, more than a doubling from her baseline, stage 2 AKI, as we showed earlier. The nephrology service is consulted. And the question that's posed is, in light of this acute deterioration in kidney function, should diuresis continue? Notwithstanding, of course, she has improvement, but she's still in heart failure. But the question is, because of her AKI, should diuresis, at least at this aggressive level, continue? So this is a topic of a very animated discussion at our kidney meetings of late. And I want to present one of many papers that I think summarizes the dilemma really well. This is a systematic review compiled by Yamada and led by Stephen Koka, a colleague from New York City. And the intent of this review was to look at various cohorts where kidney function was judiciously measured among patients admitted to hospital with acute decompensated heart failure. And so when they pooled the data, I think there were over 8,000 patients in this pooled group from this meta-analysis. Not surprisingly, acute kidney injury, those who developed acute kidney injury during this hospitalization for acute decompensated heart failure had a higher risk of death, about a 70% increase in the risk of death, not just during that hospitalization, but in a follow-up that extended to as long as, I think, 1.5 years. But what was really interesting was that among patients who were not successfully decongested, if you want to call that, during the hospitalization, the effect of AKI on the outcome of death was heightened. The odds ratio went up to 2.3, over a 2-fold increase in the risk of death. But among the patients who did achieve decongestion, the association between acute kidney injury and death was substantially modulated, in fact, to the point where it was no longer statistically significant, suggesting that maybe if a patient gets successfully decongested in the context of their heart failure presentation, perhaps the AKI that they may develop maybe doesn't really affect big picture outcomes. Other scenarios where rises in creatinine may be tolerated clinically or accepted clinically, of course, I'm sure this has been discussed many times, involve the initiation of RAS blockers, the introduction of SGLT2 inhibitors, and a big controversy, of course, surrounds the how meaningful are rises in creatinine that might occur after intravenous or intra-arterial contrast administration. So the bottom line is the purpose of presenting these scenarios is certainly not to commit hearsay as a nephrologist. I don't want to diminish the importance of even modest changes in kidney function in hospital. Acute kidney injury is a big deal. It's an issue. It's something we can't be cavalier about. But I do want to emphasize the fact that we must interpret AKI not necessarily religiously by the guidelines and classification scheme that I showed you earlier, but in the right clinical context, recognizing that in some situations, achieving good clinical outcomes and the ability to introduce and maintain patients on medications that have a strong evidence base likely outweigh whatever risk of AKI comes with that. So we have to take AKI with a grain of salt. So moving on from here into the ICU, where, as Rita alluded to earlier, I've certainly spent a lot of my time both clinically and in my research. So this is a scenario of a 70-year-old man admitted to the medical ICU with pneumococcal sepsis. He has a past history of diabetes, hypertension, and cerebrovascular disease. He's ventilated, requiring an FiO2 of 50%. He's receiving 2 pressors to barely achieve a mean arterial pressure of 65 millimeters of mercury. His baseline creatinine from the outpatient world is about 100. When he presents to the emergency room, it's 215. It's already more than doubled. And now in the ICU, when you're seeing him, his creatinine is 400. His potassium is acceptable. He has a mild metabolic acidosis. His bicarb is 19. And he's quite oliguric. His urine output over the past 12 hours is only 200 ml. And because of all the resuscitation that he's gotten and other sources of fluid that he received in the ICU and his very, very minimal output, his fluid balance has climbed to over 7 liters since admission to hospital. So I want to talk a little bit about the management of established acute kidney injury. And this is obviously a very dramatic case of acute kidney injury in the ICU. Sadly, there aren't any modalities or therapies that directly target the kidney or that accelerate the recovery of kidney function. We don't have any kidney curing medications yet, at least in the context of AKI. And so to some extent, our therapy is largely supportive. We aim to seek out and address reversible causes or contributors to the patient's acute kidney injury, recognizing that in this particular patient, sepsis is probably the major contributor, but there may be other factors that may be exacerbating his acute kidney injury. We aim to try to maintain the patient euvolemic, and that becomes very difficult, especially in patients who are might be diuretic refractory. We manage, to the extent that we can, electrolyte and acid-base disturbances. And I think it's really, really important to highlight the fact that we must pay very careful attention to drugs and their dosing, not just to the avoidance of nephrotoxins, but also to look very careful at medications that aren't necessarily nephrotoxic, but which, because of their own toxicity in the setting of impaired GFR, might become toxic to the patient. Those drugs need to be carefully evaluated and their dosing and frequency adjusted as appropriate. But these are largely supportive things that we do for our patients. So at the end of the day, and in particularly in the patients that I showed in this vignette, one of the other things that we need to do is assess the need for renal replacement therapy. And the question really is, what should be the triggers to initiate renal replacement therapy in the setting of AKI in a patient just like this? So here are a bunch of, I think, classic indications for the initiation of renal replacement therapy in AKI. None of us would argue that severe hyperkalemia that's refractory to medical measures is a pretty good reason to start renal replacement therapy for a patient. In the setting of severe metabolic acidosis is also commonly cited as a reason. Volume overload, refractory to diuretics. Oligonuria, again, this patient is oligonuria as well, but in the absence of any of the previous complications, should this in itself, even though it's commonly cited as a reason to start renal replacement therapy, should oligonuria in itself be a reason to commence dialysis? Pericarditis, encephalopathy, these are more complications in chronic kidney disease rather than acute kidney injury, but sure, these are definitely indications to start dialysis. And finally, drug intoxication that might be occurring concomitantly with the AKI might also be good inducing factors to start renal replacement therapy. But really the question in this particular patient, especially in the absence of any very florid biochemical indications to start renal replacement therapy, the question for him is, should we wait for the presence of a classic indication or an AKI-related emergency before starting renal replacement therapy? So this is really a debate or a tension between this concept of preemptive or early initiation of renal replacement therapy as compared to what I would call a more watchful waiting or conservative approach or delayed approach to starting renal replacement therapy. So I'm going to argue on this slide the plausible reasons for why we should start renal replacement therapy on the individual in this vignette. Number one, he's 7 liters over his baseline based on the flow sheets in the ICU. And so we know that if our goal is to achieve decongestion and achieve volume control, there's no more reliable way to do that than with renal replacement therapy, especially in a patient who's refractory to diuretics. And of course, the ultrafiltration on our machines, we can dial in whatever we want to get the desired volume off. By starting renal replacement therapy earlier, we'll be more effective at restoring acid-base homeostasis. This patient has a mild metabolic acidosis. Certainly by starting renal replacement therapy earlier, we will get a head start in removing the various small and middle-sized molecules that might be mediating the toxicity of AKI and sepsis. The problem with this theory, though, is that we actually don't know what the most serious or the most damaging of these molecules is or are. And some would argue that by starting renal replacement therapy earlier, we're contributing to a more rapid mitigation of the inflammatory milieu that is present in patients with sepsis and AKI. And finally, by starting renal replacement therapy earlier, we avoid the morbidity associated with a watchful waiting approach. So by starting dialysis, say at 6 o'clock in the evening on a Friday, we avoid a situation where at 4 in the morning, when there's one physician covering the ICU, the patient suddenly spikes their potassium to 6.5, and you have to start renal replacement therapy more urgently. Start it earlier, start it when there's more people around to help get things started. But I also want to present why we have to be cautious about this notion of preemptive renal replacement therapy. The number one reason really is that even though I showed you before that in the ICU, acute kidney injury is very common and stage 3 acute kidney injury is probably the most common perhaps, the vast majority of patients, even those with severe AKI, actually experience kidney recovery without ever needing renal replacement therapy. The problem is we're not very good at the outset of identifying who those patients will be. The other issue is that renal replacement therapy, dialysis, is not benign. There are iatrogenic risks of exposing patients to renal replacement therapy and the vascular access that's needed for it. And if the patients are going to recover on their own anyways, this is just exposing them to risks that they might not need. So at the end of the day, if preemptive or early renal replacement therapy does not confer clinical benefit, a watchful waiting approach to renal replacement therapy initiation will reduce complications and costs as well. So what are the clinical practice ones that were written, let's say, 10 years ago? What did they say about the correct timing to start renal replacement therapy? The first comments they made roughly were that, a fairly non-controversial statement that if the patient has an urgent indication to start, a potassium of 6.5, not making any urine, there is no question that patient needs to start on renal replacement therapy. But none of us would debate that one for sure. We would never debate that. But there's less clarity on when to start renal replacement therapy if such an indication is absent, and just like the vignette that I'm presenting. So I want to talk a little bit about prior trials, prior to the one that we completed, that have looked at the timing of renal replacement therapy for AKI in the ICU. The first of these is the ELAINE trial. The ELAINE trial was a single center study of 231 critically ill patients in Germany, most of whom had kidney injury in the setting of surgery. And they recruited individuals who had stage 2 AKI, but not stage 3 AKI, and randomized them to either starting renal replacement therapy right away or to waiting until they progressed to stage 3 AKI. And their findings are quite remarkable. They found that patients who started dialysis earlier with stage 2 AKI had any day all-cause mortality, a relative risk reduction of about 34%. But as I said earlier, the generalizability of this trial is somewhat limited because it was only done at one center. The majority of patients had AKI in the context of surgery, and nearly all patients in the delayed arm received renal replacement therapy. As I said earlier, I would have thought that many more patients with stage 2 AKI would have recovered without ever progressing to stage 3. The trial was also relatively small with a fragility index of 3, which means that if 3 patients in the early arm had passed away, had a bad outcome, or 3 patients in the delayed arm had a better outcome, they survived, the statistical significance that's illustrated here would have been obviated. Another very important trial came out of France called the Acute trial, and this group randomized individuals with stage 3 AKI in the ICU to either starting dialysis earlier or later, 48 to 72 hours later. And you can see here from the superimposed survival curves, there was no difference between the two groups in terms of 60-day mortality, which was their primary outcome. But very importantly, 50% of patients in the delayed arm never received renal replacement therapy, mostly because they died or recovered kidney function without ever needing dialysis. Another study that was done in France at around this time focused on patients with stage 3 AKI that also had septic shock. It was called the Ideal ICU trial. And here, once again, they showed no difference between early strategy, starting right away, or waiting 48 hours to start renal replacement therapy. Unfortunately, with this trial, 50%, the trial had to stop early with only 50% of patients recruited, and 38% of patients in delayed arm did not receive renal replacement therapy, again, largely because either they died or recovered kidney function. So it was on the background of these three trials, one showing a benefit to earlier initiation, two showing no benefit, that we undertook the Start-AKI trial. In fact, we had already started the Start-AKI trial before that, and I was very grateful that the investigators from the three prior trials, Elaine, Akiki, and Ideal ICU, joined the Start-AKI trial once their respective trials were complete and contributed quite a number of patients. Start-AKI really asked the following fundamental questions. In critically ill patients with AKI, does accelerated or preemptive initiation of renal replacement therapy, as compared to a strategy of watchful waiting and initiation of renal replacement therapy in the setting of a pressing indication only, reduce 90-day all-cause mortality? Who are the patients that we recruited? We looked for individuals who were over 18 years of age, admitted to an ICU, who had evidence of kidney dysfunction, and a creatinine of over 100 in women or 130 in men, and who had evidence of severe AKI defined by one of the following three criteria. Roughly, this paralleled stage 2 or 3 AKI. We excluded individuals who already had evidence of hyperkalemia or severe metabolic acidosis, because it would have been unethical to recruit such patients knowing that there's a 50% chance that renal replacement therapy would be delayed in these individuals. If they had a drug overdose, lack of commitment to escalating care, recent dialysis in the past 2 months, a kidney transplant in the past year, or already pre-existing severe chronic kidney disease, they were excluded as well. And finally, if they had what I call a weird and wonderful cause of AKI, obstruction, a rapidly progressive glomerulonephritis, vasculitis, they were excluded as well from consideration. But what we did now was we didn't just simply enroll these patients in the trial. We went back to the clinicians who were caring for the patient, and we wanted them to express their non-opposition to randomization. We asked the clinician caring for the patient whether they believed that immediate renal replacement therapy was absolutely mandated. In other words, irrespective of the patient's eligibility for the trial, if the clinician in his or her heart felt that dialysis must be started right away, we felt it would be impossible to enroll the patient in the trial on ethical grounds, especially if there's a 50% chance that renal replacement therapy would be delayed. On the other hand, if the clinician firmly believed that deferral or the non-initiation of renal replacement therapy was necessary, then too, in that scenario, we excluded the patient. And of course, this is a really, really important exclusion because, as I mentioned earlier, a lot of patients with stage 2 AKI in particular will recover kidney function. And the last thing we'd want to do is to enroll a patient and start them on dialysis if they have a version of acute kidney injury that is likely to recover rather soon. How do we know if a patient's going to recover rather soon? The clinician, we felt, was the best person to predict that. The bottom line is we wanted to make sure that attending physicians had a sense of equipoise with respect to the timing of renal replacement therapy initiation. And we're just as comfortable as having the patient start dialysis right away or have dialysis deferred. So patients we had, we were really grateful to have many centers, over 160 centers around the world participate in 15 countries, and randomization was stratified by center. In the accelerated arm, patients were to start renal replacement therapy no more than 12 hours after becoming eligible. In the standard arm, we took a completely different approach. We discouraged the initiation of renal replacement therapy or of one of these criteria was present. A potassium that was 6 or higher, severe metabolic acidosis, severe hypoxia, or if the acute kidney injury was present for over 72 hours, we simply told the patients that, or the clinicians, that they can make the decision themselves whether or not they wanted to commence renal replacement therapy. We would neither encourage or discourage the initiation of renal replacement therapy. Primary outcome of Start-AKI was all-cause mortality at 90 days. And we had a variety of secondary outcomes, which I will discuss later, the most prominent of which was the dependence on renal replacement therapy at 90 days among survivors. So here's the consort diagram for the trial. We screened over about 24,000 patients, again, at 168 sites around the world, who had acute kidney injury, who met the inclusion criteria. But then about half of them were excluded on the basis of the first 8 exclusions, most notably hyperkalemia, a metabolic acidosis, no commitment to renal replacement therapy because of philosophy of care issues. But after that left us with about 12,000 patients or so, but then we excluded another almost 9,000 patients. We excluded 2,196 patients because the clinicians simply felt that renal replacement therapy had to be started. It was absolutely mandated, and that was fine. They had no equipoise. But the most common reason for exclusion that affected almost 5,700 patients was when clinicians felt that deferral of renal replacement therapy was mandated. This is because the patient was likely to recover very soon, and there's no ethical, grounds really for including them in a trial where there's a 50% chance that they'll receive renal replacement therapy. And again, this is really, really important to us, these exclusions, because we really wanted to make sure the patients that we did ultimately randomize, and we randomized 3,019 patients into the trial, we wanted to make sure that those patients were the ones for whom the question of when to start was actually most relevant. So as the trial went on, we realized that we had about 50 patients who were randomized, but were not eligible. Another 27 patients who had really intended to recruit 2,866 patients. We got permission from our DSMB to recruit more patients. And so we went up to 3,019. That was the basis for that. And ultimately, in the analytic cohort, accelerated arm, 1,462 in the standard arm. So this is our abridged table 1. You can see that the typical patient in the trial was a man in his kidney disease. The most common reason for admission, or the most common context for AKI, I should say, sepsis. A minority had cardiopulmonary bypass as the context for their AKI. Patients had very high SAPS-2 scores. This is a reflection of acuity of illness, as well as a SOFA score that reflected organ injury in at least 3 or 4 foci other than the kidneys. The majority were mechanically ventilated on vasopressors. And at the time of recruitment into the trial, their creatinines were in the vicinity of 300, and there was a tendency towards oliguria. The cumulative fluid balance at the entry into the trial was relatively modest, between 2.5 and 3 liters. So what happened? The accelerated arm received renal replacement therapy, 97% did. And they started renal replacement therapy as the protocol called for, a median of 6 hours after meeting eligibility. In the standard arm, 903 out of 1,462 patients started renal replacement therapy. The rest, as I said earlier, either recovered kidney function or died. And again, we had very flexible, we did not mandate the initiation of renal replacement therapy in the standard arm at all. But among those who did start renal replacement therapy in the standard arm, their median time from eligibility to starting renal replacement therapy was 31 hours. And not surprisingly, patients in the standard arm at the time of initiation of dialysis had higher creatinine, higher urea, lower bicarb, and a higher fluid balance as compared to patients in the accelerated arm. The vast majority of patients initiated renal replacement with continuous renal replacement therapy. The bottom line from the trial, this is our primary outcome, mortality at 90 days. There was no difference between the 2 treatment strategies. In the accelerated arm, 43.9% of patients died by 90 days. In the standard arm, it was 43.7%. And these findings were robust in adjusted analyses, in per protocol analyses, and as treated analyses as well. And this illustrates the results of our trial in a graphical fashion. Once again, you can see the superimposed survival curves in the 2 arms of the trial.
Dr. Wald? Dr. Wald?
Specified subgroups. And you can see here that whether it's sex, chronic kidney disease, severe, yes, yes.
Can I ask you to turn off your video maybe because
Hi
you're
there.
breaking? Can I ask you to turn off your video perhaps because you're breaking up sometimes when you speak?
Oh, okay, sorry. Yeah. Sure.
Thank you.
Okay. Hopefully that's better. Hopefully that's better. Okay, perfect. So I'm just going to go back if that's okay. Sorry, back into the. So across a variety of pre-specified subgroups, as mentioned, based on sex, GFR, acuity of illness, was really no particular subgroup that seemed to benefit from an. And this was an analysis we did to the higher the SAPS-2 score, the more ill the patient. And once again, here you can see that there's no clear trend showing that that by severity of illness, a strategy of accelerated initiation made any difference on the patient's outcome. I want to speak a little bit about secondary outcomes, and most prominently, the risk of renal replacement therapy dependence among surviving patients to 90 days. And we found that there was almost a twofold higher risk of needing dialysis persistently at 90 days, accelerated arm of the trial as compared to the standard arm of the trial. I also want to highlight the fact that most other secondary outcomes did not demonstrate any difference between the two arms. Renal replacement therapy free days, duration of ICU stay, ventilator free days, none of these really showed any difference between the two groups. So patients in the accelerated arm seem to have a slightly higher risk of rehospitalization within 90 days. What about adverse events? In this trial, we focused on adverse events that were most likely to be related to the delivery of renal replacement therapy, significantly more common among patients randomized to the accelerated arm. In terms of vascular access-related events, there was a slight tendency to more bloodstream infections in the accelerated strategy, but there were overall very few such events and did not reach statistical significance. So the conclusions of Start-AKI were as follows: that an accelerated strategy of renal replacement therapy initiation did not reduce mortality at 90 days. Persistent dialysis dependence at 90 days was more common among patients allocated to the accelerated strategy. And adverse events, most notably hypotension and hypophosphatemia, were more common in patients allocated to the accelerated strategy. So now back to our patient. He received renal replacement therapy for about 10 days, and dialysis was then gradually weaned off. He was discharged from hospital with a serum creatinine of about 120, which isn't bad considering that his baseline creatinine was 100. But I want to ask now, what are the risks that he currently faces now that he's been discharged from hospital after a very severe illness? So historically, I want to contrast two perspectives on kidney recovery after acute kidney injury. The first is the traditional view, which states that if a patient survives an episode of AKI, the kidneys will be fine, and kidney outcome will ultimately follow the course of the acute illness. So that's a good thing for this particular patient. But the contemporary view, and this is based on research that's been done mostly in the last 10 or 15 years, suggests that long-term kidney prognosis after AKI may not be as benign as previously presumed, that survivors of acute kidney injury are at high risk of a myriad of health complications. And so without going into the details, because there's been a lot of studies that have shown this, de novo or worsened chronic kidney disease actually develops in about 50% of patients who have an episode of acute kidney injury. So acute kidney injury, interestingly, might be a risk factor for worsened or new chronic kidney disease. 25% of patients who survive an episode of AKI are going to have an episode of recurrent AKI in the next year. And acute kidney injury is also associated with a higher risk of cardiovascular events, de novo hypertension, rehospitalization for a myriad of reasons, as well as a variety of medication omissions and dosing errors. And so we were interested in how we can improve the outcomes of AKI survivors. And this prompted work by my colleague Ziv Harel. This was part of his master's thesis about 10 years ago. And he looked at individuals admitted to hospitals across Ontario who had acute kidney injury requiring dialysis, who survived a hospital discharge, who came off dialysis, just like the patient in the vignette. And he found that only about 40% of these patients actually saw a nephrologist within 90 days of discharge. But those who did see a nephrologist, those who had that so-called early fall with a nephrologist, they had lower mortality over time, a 25% risk reduction in relative terms in all-cause mortality. And so, inspired by this work and others, we decided that we wanted to try to improve the outcomes of AKI survivors. So in 2013, we established a clinic at St. Michael's Hospital devoted to patients who were recently discharged from hospital after an episode of AKI. And part of our inspiration for this comes from the heart failure and the coronary artery disease and the COPD literature that shows, again, that managed care or managing these patients in the outpatient world shortly after discharge from hospital after an acute exacerbation could actually be beneficial to overall outcomes. Roughly speaking, in this clinic, we recruit patients who have stage 2 or 3 AKI during hospitalization, and we aim to see them in clinic within 30 days, but up to 3 months is okay as well if we can manage it. And we follow these patients for about a year. If the patient has stable kidney function, we send them back to their family doctor with regular follow-up. But if they have some evidence of persistent CKD that we feel needs attention with a nephrologist, we'll refer them to a general nephrology clinic. So the follow-up in the AKI clinic really only lasts for about a year. So many of you might ask, what do we actually do in this clinic? There isn't a lot of evidence about what we must do for AKI survivors. So we try to do a bit of everything that we think makes sense for this high-risk group. We very much focus on blood pressure and albuminuria control. For those for whom it's relevant, we really spend a lot of time on cardiovascular risk factor modification, on medication reconciliation, on reminding patients that if they are sick, that there's a certain array of medications that they should not be taking, or at least they should put on hold temporarily. And as required, we facilitate referrals to other specialists. So does any of this work? Though we were excited about the clinic and we continue to operate it, we wanted to know, can we actually do a study to see whether this makes a difference to important clinical outcomes? So my colleague, Sam Silver, who is a associate professor of nephrology at Queen's, led this trial called Fusion. It was a 4-site trial in Toronto, whereby we randomized patients to either getting clinic care or usual care. And the primary outcome was major adverse kidney event, which comprised death, dialysis, or CKD progression. We found 269 patients who were completely eligible, and we approached them to participate, but we were maybe humbled to find out that only 71 agreed to be recruited. Many of them really had some misgivings about participating in a clinical trial. Many didn't really appreciate what AKI meant in the context of a complex stay in hospital. You can imagine a patient who stayed in hospital for 3 months with a complex sepsis and other complications. And the AKI may not have registered on him or her as something being relevant and something worthy for follow-up. Many patients were concerned about having too many physician appointments. And because we're a referral hospital in downtown Toronto, especially ours at St. Michael's Hospital, where most of the patients were recruited from, a lot of the patients were going back many hundreds of kilometers from Toronto and really didn't want to come back to St. Mike's or anywhere in Toronto, frankly, to be followed in an AKI clinic. These are the patients that we managed to recruit. The majority were men in their mid-60s, similar actually to the Start-AKI trial. About half of them had spent time in the ICU. They had relatively preserved kidney function prior to their hospitalization. Baseline GFR was around 75. When they left hospital, their GFRs were in the mid-50s, although these need to be taken with a grain of salt because GFR estimates may not be accurate in the setting of acute illness. Thing that I want to highlight, there were no different, not surprisingly, the trial was not powered to look at important clinical outcome differences between both treatment arms. But I want to highlight the fact that major adverse kidney events, mostly chronic kidney disease, de novo chronic kidney disease, or worsened chronic kidney disease, was quite common in both groups in the trial. And hospitalization occurred in over 50% of patients in the trial. Again, reminding us that this is a very unstable, very vulnerable population. So having completed the Fusion pilot trial, we're kind of gone back to the drawing board and working with colleagues in the States, and Sam is starting a new trial at Queen's as well that hopes to kind of modify post-discharge AKI care that will hopefully reduce dependence on return hospital visits. We hope to use telehealth, home blood pressure monitoring, other point of care monitoring techniques to look after these patients. And maybe the patients don't need to see nephrologists, maybe highly trained nurse navigators could carry out this multidisciplinary intervention, and again, with minimal visits by the patient hospital. So in conclusion, I want to just recap that acute kidney injury, even when it's ostensibly mild, is associated with adverse outcomes. But I want to emphasize that this should not imply causality. There are several clinical scenarios where I think we can achieve important, meaningful clinical benefits for patients despite there being a higher risk of AKI. Critically ill patients with acute kidney injury do not benefit from preemptive initiation of renal replacement therapy in the absence of urgent AKI-related complications. And finally, survivors of AKI, we have to remember, are a high-risk group of patients, and I think they might benefit from closer surveillance following hospital discharge. We just need to figure out what the most efficient and effective way to do this is. With that, I want to conclude and thank the many people who've collaborated so effectively with me over the years. I'm very grateful to my friend and colleague, Sean Bagshaw, who's the chair of critical care medicine at the University of Alberta. He was the co-PI with me of the Start-AKI trial. And as I mentioned, Sam Silver from the Division of Nephrology at Queen's, he's really doing fantastic work in the area of post-AKI care. The Start-AKI trial couldn't have been done without over 800 investigators from around the world, but I want to really highlight the contribution of the MUHC. It was such a great thing to be able to come back to the MUHC to work on Start-AKI. And I want to mention the hard work of Josie Campisi, who is the lead research coordinator in the ICU, and my collaborators, Shelley Magder, Asana Lam, and Han Yao. So thank you very, very much for your attention. I want to acknowledge as well my funding and my endorsements, and happy to open it up to questions.
Thank you very much, Dr. Wald. That outstanding, very, very interesting work that you've done to advance this field. So thank you very much for sharing that presentation with us. We have a few minutes for questions. Please enter your questions in the chat. I see a question here by Dr. Pilote. Should these definitions of AKI vary by sex and race, as classifications may impact interventions and outcomes?
So I think it's a great question, Louise, and certainly in the Start-AKI trial, we were particularly concerned about race, recognizing that women who may have, on average, a lower muscle mass, increments in serum creatinine that are more modest in women might actually have, equally important prognosis. And we incorporated that into the inclusion criteria of Start-AKI. Race, I would argue, is a bit more tricky. And in fact, many of you might be familiar with the controversy about including race in definitions or in the calculation of the estimated GFR for chronic kidney disease. And there was recently a couple of papers in the New England Journal that moved away from that. But I definitely think you're right, Dr. Pilote, that at the end of the day, these kind of cookie cutter definitions for AKI are really just a starting point. The patients, a larger, more muscular patient might have, AKI, the threshold for AKI may be very different in him or her than someone who is less muscular, for example. And I think there are many other, other variables that might create nuance when we look at definitions for AKI. Rita, thank you. I'll read your question and then try to answer it. I know that the fluid balance was much higher at baseline in the standard group. So the fluid balance was higher in the standard group at the time of renal replacement therapy initiation. At the time of randomization, fluid balance was about 2,700 mils in both groups. But in the standard group, as you probably would expect, because we waited longer to start renal replacement therapy in those patients, more fluid accumulated over time as compared to patients in the accelerated arm who started renal replacement therapy virtually right after randomization. So ventilator days, there was no, I may have gone over this slide too quickly, Rita, I apologize, but there was no difference in ventilator-free days between both groups. It's a really important question, a really clinically important outcome. We did not see any difference between the two groups in terms of use of ventilator days.
Were Lasix challenges monitored in either group for Start-AKI?
Thanks so much. That's really a great question. We were, when we designed the trial, if I can just go back a little bit, we were influenced by a group of studies that describe what was called the so-called furosemide stress test, or FST, that stated that patients who do not respond to Lasix are more likely to progress to higher stages or worse stages of acute kidney injury, maybe even more likely to need dialysis. And many argue that we should use that as a entry criterion for Start-AKI. We elected not to, but did in the protocol give clinicians and investigators the option of using a so-called Lasix challenge or furosemide stress test to help decide whether a patient was appropriate to be randomized into Start-AKI. We didn't monitor it though very systematically. In our baseline data, we did collect information on whether a patient received diuretics prior to randomization, but we didn't, unfortunately, in retrospect, collect information about how systematically that Lasix challenge was done or how appropriately it was done.
We have a question for Dan Bloom there. Can you see that question?
Yes, I do. Thanks, Dan. Good question. So Dan's question is, what happens to patients allocated to the standard arm who presumably didn't start on renal replacement therapy, who remained oliguric 72 hours after randomization? We unfortunately don't have data on that. At least don't have it at my fingertips. We looked at urine output among patients who started renal replacement therapy. We didn't necessarily look at it in those individuals who, despite remaining allogeneric, may not have started renal replacement therapy at 72 hours. So unfortunately, I don't have a good answer to your excellent question.
Thank you so much. We're going to have to stop there because it's coming up on the hour. I'd like to thank you very much. Terrific presentation. You have some great comments out there. I'll let you continue to read the comments and the questions in the chat. It's great to see our alumni out there, doing wonderful work and being so successful. So thank you on behalf of the Department of Medicine. Thank you for joining us today, and good luck with your sabbatical, and wishing you the best. And thanks everyone for joining us this afternoon.
Thank you everyone for joining.
Thank you. Bye-bye.